Go ahead and get started. Can y'all hear me in the back? You hear me in the back? How about those guys back there? Are we good? Okay. All right. Well, I'm Clifford Courville. I'm one of the pulmonologists over here at Memorial Hospital with the Memorial Medical Group. And today, we're going to talk a little bit more about lung cancer, focusing specifically on diagnosis. My last talk at one of these meetings was talking about screening for lung cancer and how do we find it. And now we're going to talk today about what we do after we do find a spot on somebody's lung. How do we go about getting a diagnosis and talking about some of the new advancements that are available to making that happen in a safe way. Let's see here. Is it going to... There we go. So just as a brief introduction, what is lung cancer? Lung cancer is any cancer that begins in the lung. It's what we call primary lung cancer. 95% of these cancers will fall into one of two groups, either a small cell carcinoma or non-small cell carcinoma. These designations are made for the purposes of treatment, and that non-small cells are those that we often will try to resect or cut out if possible, and small cells are treated just a little bit differently. But these two will comprise 95% of all lung cancers. It is the second most common cancer diagnosed overall, but it is the #1 cause of cancer death overall. That has to do with the fact that many times it presents at a late stage, and therefore we are behind in lung cancer treatments as compared to other cancers such as prostate cancer and breast cancer, which have a much better outcome. Locally, lung cancer is the most common cancer diagnosed. This is data from up to 2015, and this is the curve for incidence of lung cancer. And as you can see, as of 2015, lung cancer diagnoses were going up. This is breast cancer. It was sort of plateauing out. As of 2017, this data is not available in a chart form yet, but this line crosses, and so as of right now, lung cancer is the most common cancer diagnosed locally. So how do we go about fighting this? Well, we talk about prevention. Smoking cessation or not starting smoking is going to be by far and away the most effective way to prevent lung cancer. There are some other entities that go into increasing one's risk for lung cancer, such as radon exposure, occupational exposures. Those are also very important, but this is where sort of the low-hanging fruit that we should really be thinking about. More than just preventing lung cancer, in addition to preventing lung cancer, we talk about how do we find lung cancers, and that sort of centers around my last talk where we talked about finding those individuals who are at the highest risk for lung cancer and performing screening tests. And this screening test is going to be in the form of a low-dose CT chest, which we had talked about during our last talk, if you recall. And then if one has a low-dose CT chest, or they have a chest x-ray, or if they have any CAT scan for any reason, they find a spot, how do we go about diagnosing lung cancer? It always begins with, a history and an exam with your physician. Maybe there's a symptom that you have that's concerning, such as a cough or shortness of breath or weight loss. This would then lead one to have a chest x-ray or some type of image performed, which would identify a spot. Again, chest x-ray can find spots, but not going to be as sensitive as a CT chest. If there's an abnormal picture, such as a chest x-ray or a CT chest, this may lead one to get what's called a PET scan, which is basically a whole body image. We'll talk about that in a moment. Sometimes we'll do repeat x-rays or repeat CT chest to see if the spot is changing in a concerning manner. And then we identify those individuals who may be candidates or who have an indication to do a biopsy. And then we'll talk a little bit more today about those techniques and what's involved. A PET CT is something you often hear about in terms of the diagnosis of lung cancer and the staging of lung cancer. It is generally a whole body scan that goes from the neck down to all the way down to the feet. In some instances, it uses glucose or sugar that is tagged to a radionuclide marker, And basically, when you inject this sugar into the bloodstream, it will glow. It will cause an area to glow that uses sugar. So the heart glows because it's pumping constantly using sugar. The brain glows because it's constantly thinking and using sugar. But a spot in the lung that is suspicious, see here's a little tiny spot. Here, you can barely see it, it's glowing. So that makes it suspicious for being a cancer. It increases the likelihood that we're looking at an early cancer in this instance. And this would then propel us to pursue a biopsy or treatment of some sort. Serial CAT scans and serial chest x-rays are also very helpful. Just as an example, I made this circle here. This is not a real tumor. I made this up. But you might have a spot like this, a round circular area. You get a repeat x-ray a few months later. This is another CAT scan, and it grew. So I would say this is very suspicious for being a cancer. You can almost guarantee it's going to be a cancer or something that needs to be removed or treated, and that would propel us to pursue additional diagnostics as well. This CT surveillance is one of the diagnostic tools that we use in the diagnosis of lung cancer. There is a slight risk with waiting 3 months to doing another CAT scan. There's a risk of delaying diagnosis. There's also the risk of exposure to additional radiation with each additional CT. Each spot that you find on a CAT scan will need to be followed for an interval of time, up to 5 years. This will lead to at least 3 or 4 more CAT scans that need to be done. And then every time you do a CAT scan, there's always a chance that you find another spot. So 10% of patients will find new spots on each additional picture, and each of those spots will need to be followed or biopsied and so forth. So those are the main risks with CT surveillance, but the benefits, no biopsy involved here. You just sort of keep an eye on things. Sometimes this is necessary if a spot is very small, it's too small to biopsy, it's too small for a PET scan to be useful. If a person has low risk of having lung cancer, then this is a good approach. If somebody has a spot that is suspicious, they have a lung nodule that either is growing or it's active on PET scan, then we can talk about doing a biopsy or some type of surgical intervention to treat it. There's going to be a variety of techniques which we'll go through. Each of these techniques will vary in terms of the safety and the risk associated with them, the yield or how likely it is that we're going to be able to get a diagnosis using that technique, how fast we're able to get that biopsy done. If there's a procedure that's not available in town, maybe it's only available in Houston or Baton Rouge, that's going to represent a delay in terms of getting a diagnosis. Where that spot is located will affect which choice we make in terms of making a diagnosis. We also want to anticipate if this is a cancer, what stage do we think it is? Because that will also influence how we pursue a diagnosis. And then, of course, maybe this should be at the top. What are the patient's values and preferences for pursuing a biopsy? Are they worried about needles? Are they worried about scopes? We take all those things into account. When we're talking about getting a biopsy of the lung, I'll start with this list here. Bronchoscopy is probably going to be the most common way in which we get a diagnosis or pursue an evaluation. This may be with an ultrasound attached to the scope. We'll talk about this. This may be with some type of computer-guided or image-guided technique, such as with this navigation or super dimension technology, which we'll talk about today. There's another way to use an ultrasound to get a biopsy as well. CT-guided biopsy performed by radiology. We'll talk about that. There's always the surgical approach. You know, if there's a spot that's growing, it looks very concerning for cancer. What if we just get the surgeon to cut it out and we'll be done with it? So that's always an approach as well. And then there's the biopsy of other spots, such as the skin, the liver, the bones, etc. So what is bronchoscopy? This is your scoped procedure. This is a tube with a light and camera on the end using fiber optics. It was first done in the late 1800s by this guy here. And this is how they used to do it, with a long rigid scope, and they would just have you sit in a chair and they would drive the scope down your throat and look. And that's how they first started doing bronchoscopies. It's much more pleasant than that now, and now we use Again, a scope, it travels through the mouth or the nose, and it drives down into the lower airways. It's the light on the end so we can see where we're going. And if somebody's got a little spot out here on the end, then we can send a little biopsy out to take a piece of it. These procedures are generally done under conscious sedation, so that's sort of the semi-awake approach, or with general anesthesia. They're generally your same day. They take anywhere from 10 minutes to no more than an hour generally, and often outpatient, you go home the same day. This scope procedure has the benefit of providing an airway inspection and looking inside the bronchial tubes to see if we see anything suspicious. Usually we can send out catheters containing a brush, a needle, or a little forceps. Here you see this little tiny catheter coming out. It's got a little forceps on it. This forceps is no bigger than the size of the end of a writing pen, so it's pretty small. You're getting tiny little pieces of tissue. It's better for lesions that are close to the airways. The risk of this type of approach is going to include collapsed lung, bleeding, problems related to the sedating or anesthesia medicines themselves, but generally a very safe procedure, again, generally outpatient and done in a short amount of time. There's more advanced bronchoscopy techniques. You take that same scope that I just described before and you attach an ultrasound to it, and then we can see areas that are outside the airway. Here is an ultrasound image, and there's a lymph node here or a mass, and we're sticking a needle in it. All real time. So basically you have a direct visualization of the biopsy being performed in the tumor itself. This has now become the most common diagnostic technique for lung cancer diagnosis. It's slightly longer than the traditional bronchoscopy. It generally lasts about 30 to 40 minutes. I generally prefer to use general anesthesia for these procedures, just given the longer time it takes. It's also outpatient for the most part. We never really would admit somebody to do this procedure. It uses a needle to do the biopsies, ranging from a 19 gauge to a 22 gauge. This is the size of an IV, approximately. And we're sampling this target under real time, but the risks are similar to conventional bronchoscopy in terms of anytime you stick a needle anywhere, there's a risk of bleeding, a risk of collapsed lung. This is a very intricate procedure in the sense that you can biopsy lesions or lymph nodes as small as 5 millimeters, and so you can imagine how small of an area that you can go after with this, so again, very sensitive. And this is kind of what it looks like. This scope here is going through the windpipe. This is the trachea. It's got this ultrasound here on the end. It's looking for lymph nodes. Lymph nodes they're all over the body, particularly they ride along the windpipe in your respiratory tract. This is a map of all the lymph node areas that we focus on whenever we're doing this procedure. These lymph nodes sit right along the windpipe here. And in the setting, if there's a cancer or if one is enlarged in a concerning way, this scope can travel down here, use the ultrasound to see this area, and stick a little needle into it to sample it. I'll say that this hospital, we're the only ones offering this procedure in town as of right now. They do it in Lafayette and they do it in Houston, but we're the ones that offer it here in town. Another type of image-guided biopsy is going to be with a bronchoscope using navigation to help guide direction to a lesion that is suspicious. It's preferred for lesions that are out on the edge of the lung, and I'll kind of show you some pictures to kind of give you an idea of what that might look like. The system we have is something called a super dimension navigation system, and it uses this what they call a lung GPS technology. You basically have a CAT scan, and we overlay it with the patient so that we have another way of sort of knowing where we are in space, and we use that computer to guide us to an area that is suspicious. Again, we use this high-definition CAT scan to map the airways, and it's able to increase. Why would we use this technique? Well, with a conventional biopsy without an image to guide us, maybe we only use just a two-dimensional X-ray to guide us. The yield for doing some peripheral areas in the lung may only be about 40% or 50%. This can increase the chances of getting a diagnosis, basically up to 88%, without really changing the risk. So it's a nice tool to have to try to get areas that are small, a little further outside of view. And again, we might reserve this for lesions that are very small, ranging as low as 1 centimeter. This is how this setup might look. A patient is under general anesthesia. We've got a computer tower here. We have this might be me holding a scope with this tool here that lets me drive to the area in question. And we have sort of basically two ways of knowing where we are and that we're in the right spot, both with this computer and with the regular fluoroscopy two-dimensional X-ray. There are other navigation modalities out there, other types of equipment. This one's kind of neat. This is the controller where somebody is actually driving a robot to do the bronchoscope. This is relatively new. We obviously don't have this here yet because I'm not sure how safe it is. But maybe this is something we're using a few years from now, basically where I'm playing a video game with a game controller doing a procedure. This is another piece of equipment also with a game controller and a catheter that comes out, and you basically drive through those airways, kind of like driving a little car on a video game. So what are the steps involved to have this procedure done? Well, we know somebody has a suspicious area on a CAT scan or an X-ray. We do a planning CT scan before the procedure. We perform this bronchoscope with general anesthesia. It takes about 30 to 40 minutes to do the procedure, sometimes up to an hour, but the patient generally will go home the same day, hopefully with the diagnosis. The advantages of this procedure over other types of approaches: the main alternative to doing this procedure will be to have a CT-guided biopsy. There's a lower rate of collapsed lung or pneumothorax with this procedure than it is with the CT-guided biopsy. We can target smaller lesions with this procedure than we can with conventional bronchoscopy. We can also use this procedure to place what we call tumor markers or fiducials near the tumor to help target an area for radiation. So sometimes the radiation oncologist will send a patient to me who has a known lung cancer, an early stage, and they just want to do high-intensity radiation to treat it. He'll send the patient to me. I'll use this equipment to put some tumor markers near the tumor, and that'll help them sort of narrow that beam of radiation right at the tumor. Another approach for a peripheral lesion, kind of towards the edge of the lung, is going to be what we call a CT-guided biopsy. This is ideal for lesions that are close to the edge of the lung. You can use this approach for lesions that are closer to the center of the lung or closer to the center of the airways, which is a much higher risk of complications such as bleeding and collapsed lung. This is a very high yield procedure. There's about a 90% chance that they're going to get the diagnosis. I'll show you a picture as to why that is, because they're doing a CAT scan, they're sticking a needle in exactly where that lesion is. But there's about a 20% chance that the person's going to develop a collapsed lung with this procedure, which, if it's a 90% chance of getting you the diagnosis, well, you may have to come into the hospital for a couple of days if you develop this complication. So for some people, it's an acceptable risk. This is performed by the radiologist. It's not useful for lymph nodes or areas that are more in the central part of the chest. That's its main limitation. And also an outpatient procedure. It takes about 30 minutes or so. This is what that looks like, where someone's got a spot here, very suspicious for being a cancer. It's spiculated, it's kind of lobular, solid, and the radiologist is basically doing the CT scan, and they're sticking this long needle through here and taking a little piece out of it. This person's probably going to have a collapsed lung after the procedure, given how much lung they had to go to. So if this lesion were over here closer to the edge, it'd be ideal for this type of approach because it would lower the risk of a collapsed lung. For areas that are more in the center, maybe over here, that's a much longer distance the needle has to go. That influences our decision as to whether to pursue this approach or to do the navigational bronchoscopy. And then there's always the surgical approach. This lesion is suspicious. It's probably a lung cancer. I mean, it's probably 99% that it's a lung cancer. Without even doing a biopsy, some people would say, just go in and remove that lobe and cut it out. It would treat the lung cancer and get a diagnosis at the same time. So that's one approach that could be done. So we say open lung biopsy or lobectomy as approach for diagnosing these areas. A mediastinoscopy is a surgical procedure where an incision is made at the top of the sternum and a scope is driven down to biopsy those lymph nodes. So this is another way to get lymph node sampling or to biopsy lymph nodes that are right next to the windpipe. So that's something we kind of keep in our armamentarium, and we may consider that at some time. There's also the option to biopsy distant sites. These cases are generally not, we're diagnosing stage 4 disease at this time. This is cancer that has spread to a different site. Either the patient has developed a fluid collection on the lung, or a spot has developed in the liver or the bone or the adrenal gland. And so you do the biopsy knowing, though, that if you get cancer out of that area, and if it's from the lung, that is, you confirmed a stage 4 diagnosis. So these are things that we also, look into as well. So how do we choose our approach? I mentioned all of those factors that go into choosing a procedure, whether it's patient risk or preferences, the size of the lesion, the location. So here are some examples of areas that are suspicious. Here's a great big area here, right around this airway. This might be done with a conventional bronchoscope. This might be done with navigational bronchoscopy. This area here is large, right up against the airway wall. I might use that endobronchial ultrasound to come right here and stick a needle right here into it to get a sample. This area here is right on the edge. It'll be very easy for radiologists to come in from the outside and stick a needle in from this direction. This area is tricky. It's not very big. It's small, right here in the middle. With a needle biopsy from the outside, you're probably going to collapse the lung. I know with a bronchoscope from the inside, I may have a hard time finding it even with my navigation equipment. Maybe we would just watch this spot, see if it grows in a couple of months. Maybe we would do a PET scan to see if it's active. If it's very active, we would be convinced that maybe it's a cancer, and we might recommend a surgery to remove it. So those are all the different ways that we look at these spots in the lungs and the way we decide which type of approach to take. We use words like an individualized approach and a multidisciplinary approach. What this means is that each patient is different. Each spot is different. We may use a CT scan or a PET scan to predict what is the stage of cancer. If it's a cancer that's going to be unresectable, it's one that is advanced, perhaps spread to lymph nodes or spread to distant sites. We just need a diagnosis, so we'll do the procedure that is the safest, the quickest, just to get them a diagnosis, but knowing that they're not going to have surgery. If there is a spot that's distant, that will be our approach. If it's an area that's a stage 1, then that we may consider doing surgery right off. We may consider doing one of the bronchoscope or CT-guided biopsy approaches. Multidisciplinary means that we have to communicate with each other. So I have to talk with the interventional radiologist who may do the CT-guided biopsy. Do they think they can do this biopsy safely? I may talk to the thoracic surgeon. Does he think we should just remove this, what appears to be an early stage tumor, or does he want a tissue diagnosis first? And then always keeping in mind that we're talking about cancer, so oncology is going to have to be in the loop at some point. What the future holds, there's a lot of things out there that is becoming more available. This idea of a liquid biopsy is becoming more popular. This is a blood test. Even with people who have early stage cancers, can have DNA from that tumor circulating in their bloodstream. And so basically with a blood test, you could potentially diagnose a cancer that's not in the blood. It's kind of weird how that works. This is already available. At this point, you would not do a blood test to confirm cancer. You would do the blood test to help complement another form of biopsy technique. So if you do a lung biopsy, you may send off the blood at the same time, and you would use all that information together. But in the future, as our molecular chemistry becomes more advanced, we may see this become a possibility in the future. This was just something I was reading about recently, where basically you apply a certain light during the bronchoscope to look at the airways, and you can see early changes with the way the airways reflect light, and basically you can identify cancer basically just with this special camera without doing a bunch of biopsies. So that may be something that we have available to us in the future as well. In conclusion, and we'll kind of stop here and just open it up the door for questions, we talked about lung cancer beginning with prevention and smoking cessation, or not even starting smoking. And I'm going to throw my plug in about vaping being perhaps a gateway for young people to get their hands on nicotine, which has been a way for been away from it. Many of them may start smoking in addition to the vaping itself, which may be harmful. There's a lot of stuff in the news about vaping being related to certain respiratory illnesses. We don't know about what the long-term effects are going to be. So again, stopping smoking or not even starting, including vaping, must be emphasized. Early diagnosis in those individuals who are high risk for lung cancers, smokers of a certain age, numerous family members who have lung cancer, those are the ones that we talk about this, and getting that low-dose CAT scan annually may be beneficial. And God forbid you have a spot, we take that individualized approach to either observing or sampling or doing a surgical approach to treat the area of concern with the help of a multidisciplinary team. You know, today highlighting some of these new techniques that we have, endobronchial ultrasound, the navigational bronchoscopy to guide biopsy, certainly nice to have those available. I'll stop there and kind of open the door up for questions.